You are listening to the Journal of Rheumatology's Editor's Picks with Dr. Earl Silverman, Editor-in-Chief.
Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you to the May 2025 edition of Editor's Summary. This month, Dr. John Davis, Section Editor for Rheumatoid Arthritis, will be interviewing Drs. Kapeluznik, Romero, and Bonin from Maastricht University and Leiden Medical Center, the Netherlands, regarding their article titled Unacceptable Work State in Rheumatoid Arthritis, Establishment of Thresholds for Presenteeism and Clinical Measurement Instruments.
Getting into the implications of the findings, maybe you can tell us about what you have learned from this study in terms of your next steps for either further research or how you would think about moving this into the practice. If you could speak to the fact that actually you've got several questionnaires there, and I'm wondering which ones you would implement or take forward, since it may not be practical to ask four questionnaires, or how you're approaching that with your work going forward.
I will take this one, John. Thank you very much. Yes, definitely very good question. Although it was not our objective to assess which is the best performing instrument, that would need another methodology. But the WEPI, Presenteeism, is the most commonly used instrument. And in our study, it actually performed the best in identifying patients who may benefit from a tailored care. So answering your last question, which of the four would we bring forward? Then we would select the WEPI, which is more widely used and has performed the best. And what are the implications of this study? Well, work outcomes are not always consistently collected in our daily clinical practice, but they are important and they have a huge impact on patients' daily lives. Maybe now with times in which we can make use of patient-reported outcomes that can be collected in advance through the electronic medical records, and we can receive responses from patients ahead of the consultation. A WEPI questionnaire could be a very simple way to be informed about the work status of patients. And with these cutoffs, we could very easily signal patients that may need some more tailored care. Also because there's literature showing that higher levels of presenteeism are associated or lead to withdrawal from workforce. So either sick leave or work disability permanently. So if we can identify these patients earlier down the road, then we can know who are the patients that eventually can benefit from tailored treatment and maybe tailored care. And I'm already responding to your next question, which is how can we bring this forward? What could we do? That's one possibility, by identifying those patients that required more tailored care, whether interventions are efficacious on them. And on the other hand, as Daphne mentioned in the beginning, although this analysis or the outcome of this paper is not meant per se as an outcome of a trial, having cutoffs for the WEPI also allows to analyze trials with this outcome or of being or not in an acceptable work state, or whether and if patients are on it or leave it or lose that acceptable state or get it that acceptable state that they did not get before. That's also a possibility of looking into the data in that perspective.
I hope you enjoyed listening to part of Dr. John Davis's interview with the authors of their paper, Unacceptable Work State in Rheumatoid Arthritis, Establishment of Thresholds for Presenteeism and Clinical Measurement Instruments. And we'll listen to the full interview, which is available at our website, www.jrheum.org, on our YouTube channel. We begin this month with a review article by Abel and co-authors titled Historical Perspective on Anti-Nuclear Antibody Testing. In this review article, the authors present historic and contemporary ANA testing methods, highlight the pros and cons of each method, as well as reviewing recently published surveys and standardization of methodologies. The authors propose that These new standardizations will lead to new diagnostic guidelines. Now, moving on to original articles. The first original article examines the issue of the safety of nintedanib in RA-related interstitial lung disease, or RA-ILD. In this multi-center registry, Sebastiani and co-authors, which is titled Nintedanib in Rheumatoid Arthritis-Related Interstitial Lung Disease, a Real-World Safety Profile and Risk of Side Effects and Discontinuation, 65 patients with RA-ILD were examined from the Italian GISA registry. The majority of patients were described nintedanib in combination with a DMARD and or steroids. The 12-month retention rate was 76.7%, and the drug was deemed to be effective in approximately 80% of the patients who had at least 6 months of follow-up. Adverse reactions were recorded in 36% subjects, of which were mainly gastrointestinal. Comorbidities were significantly associated with side effects by multivariate analysis, and adverse events secondary to nintedanib were the main cause of medication discontinuation. There is an accompanying editorial by Keeley and Shake from the James Cook University Hospital, Middlesbrough, United Kingdom, titled Practical Issues regarding to the use of antifibrotic therapy in patients with interstitial lung disease and rheumatoid arthritis. The authors review this paper and give their perspective on this issue. Patients with RA have an increased risk of infection and mortality from infection. Emery and co-authors used data from the AVERT-2 study in their paper Association between Abatacept exposure levels and infection occurrence in patients with rheumatoid arthritis post-hoc analysis of the AVERT-2 study to determine if higher serum exposure to subcutaneous abatacept was associated with an increased risk of infection in RA patients. They found serious infections occurred in 1.6% of patients treated with abatacept plus methotrexate, and in 1.3% of patients with abatacept placebo and methotrexate. They found no relationship with exposure to abatacept and increased risk of first infection. Similarly, the concomitant use of methotrexate and their glucocorticoids did not increase the risk of first infection. This is reassuring data for the use of abatacept. It is recommended that in clinical practice, patients with axial spondyloarthritis, or AxSpa, should have their disease activity monitored using validated indices, specifically the BASDAI or ASDAS. In their study titled Performance of Disease Activity Indices Used in Axial Spondyloarthritis in Real-World Setting, Alonso and co-authors examined 330 patients with axial SPA and routinely measured the BASDAI, the ASDAS, the BASFI, and the SSHI indices to determine the correlation, degree of concordance, and discriminating capacity of different levels of disease activity and the impact among the indices. Concordance between the instruments was substantial, both with regard to the different activity thresholds and the different disease impact categories, except for those at low disease activity. Regardless of systemic therapy use, there was substantial agreement between the BASDAI remission and the ASDAS inactive disease categories. The authors concluded that the indices could be used interchangeably in routine clinical practice despite the relative lack of concordance between the indices at low disease activity. An accompanying editorial titled Assessing Disease Activity in Axial Spondyloarthritis, Finding the Balance Between BASDAI and ASDAS, Dr. Antonio Chan from the Royal Berkshire NHS Foundation, Reading, United Kingdom, reviews the clinical implications, the remaining challenges of the findings of Alonso et al., and suggests considerations for future research. Previous studies comparing the clinical characteristics and prevalence of HLA-B27 in patients with radiographic axial spondyloarthritis, or RAxSpa, have found differences in patients between those from Latin America and European countries. In their study titled Clinical Expression of Radiographic Axial Spondyloarthritis and its Association with HLA-B27 in European and Ibero-American populations, Pouchet, Ayaruba, and co-authors examined this issue in 2,592 patients with a clinical diagnosis of R-axial SPA. 41.8% were Iberian American patients and 58.2% were European. Clinical manifestations varied across racial groups, in particular regarding the prevalence of peripheral joint manifestations, with more arthritis and enthesitis seen in the Ibero-American than in white and black American patients. The Ibero-Indian patients had more structural damage and worse function than the European patients, regardless of the presence or absence of HLA-B27. In a previous study, it was shown that there was a benefit of a treat-to-target approach in patients with early psoriatic arthritis, or PSA, regarding normalizing function, improving social participation, and enhancing health-related quality of life. In a current paper titled Tight Control on Radiographic Progression, the radiographic outcome of the TICOPA study, James and co-authors examined if a treat to target to achieve low disease activity altered radiographic progression in 169 patients from the tight control of PSA, or TICOPA cohort, who had radiographs at both baseline and at week 48. 84 patients from the tight control group and 85 received standard of care. At week 48, only majority of patients, or 10.1% of the total cohort, had radiographic progression, 14.1% in the standard arm, and 5.9% in the tight control arm. Tight control had no effect on erosion score. The authors suggest that the reason for these negative findings were that patients in this study had early mild disease, there was no comparator to placebo, and that the standard of care group had a step-up treatment protocol. I leave you to decide for yourself what your conclusions are. It has previously been shown that bimekizumab, an inhibitor of both IL-17F and IL-17A, showed efficacy for both joint and skin outcome in patients with active psoriatic arthritis. In the current paper titled Effect of bimekizumab on Patient-Related Outcomes and Work Productivity in Patients with Psoriatic Arthritis, 1-year results from 2 phase 3 studies, Gladman and co-authors examined the effect of this monoclonal on patient-reported outcomes, health-related quality of life, and work productivity. In this pooled analysis, patients were either biologic naive or had an anti-TNF response that was inadequate, or they were intolerant of this treatment. Patients then received bimekizumab or placebo until week 16, and then all patients entered a open label bimekizumab extension phase. Greater than 90% of the 780 initially randomized patients entered into the extension phase. Overall, the study showed significant reductions in pain, fatigue, with improvement in physical function, HAQ-DI, and SF-36 physical component score, and that these reductions were sustained to the end of both trials. In addition, there was an increase in the portion of employed patients as compared to baseline. The next paper to discuss is by Plantinga and co-authors, and is titled Indicators of Functional Disability by Receipt of Disability Benefits Among Individuals with SLE. Many previous studies used the receipt of disability benefits in the United States to define functional disability. In this study, the authors found that of the 443 patient studies, 45.6% were receiving disability benefits after a median disease duration of 14.8 years. The median age of patients was 46.2%, 91.7% were women, and 82.6% were Black. Although patients receiving benefits were more likely to have impairment in physical performance, fluid cognition, which is the overall capacity to reason and solve novel problems, limitation in all activities, and restriction in participation in work. However, importantly, significant limitations were also found in patients not receiving benefits at 7.5%, and 19.2% had limitation in physical and cognitive function, respectively. 22% had restrictions in mobility, and 42.9% in activities of daily living. Impairment in physical performance was seen in 50% of the patients. Lastly, among those currently working, 60.6% reported some level of restriction of their work related to the disease. The authors concluded that it's not sufficient to only look at patients on disability benefits to determine the effect of lupus on patients' life. It is well recognized that patients with inflammatory arthritis have an increased risk of cardiovascular disease that cannot be explained by traditional risk factors alone. In their study titled Risk Factors of Heart Failure in Patients with Immune-Mediated Inflammatory Diseases, a population-based study, Kopitar and co-authors used administrative data from the province of Ontario, Canada, to look at the risk of hospitalization for heart failure in 243,061 patients with an immune-mediated inflammatory disease, specifically RA, radiographic, axial SPA, PSA, and psoriasis. They then compared this to a cohort of almost 750,000 patients with diabetes and greater than 8 million patients without either diabetes mellitus or an IMID. All individual IMID groups had significantly higher rates of hospitalization for heart failure compared to the non-DM patients. The rate of the total cohort was 30% higher than that found in the control group. the non-IMID, non-diabetic patients. Within the IMID group, the patients with RA had the highest incidence of hospitalization for heart failure, while patients with psoriasis alone and radiographic axial SPA had the lowest. As expected, the risk of admission for heart failure was significantly attenuated, but still remained increased in patients with both IDIM and diabetes as compared to the control group. Of note, the rate of hospitalization for patients with DM alone was higher than that found in the total IMID cohort. A non-ischemic etiology, specifically atrial fibrillation, was the most common comorbidity in patients with heart failure. Previous work has highlighted a need for more pediatric rheumatologists and allied healthcare providers in Canada for the treatment of pediatric rheumatic disease. In addition, there is a geographic imbalance in Canada. The next paper to bring your attention to is titled Pediatric Rheumatology Care in the Canadian Context, a qualitative analysis of care providers, and is by Dushnicki and co-authors. Using semi-structured interviews with pediatric rheumatologists and allied healthcare providers, the authors found that three major themes emerged. One, as expected, in a large country such as Canada, there were geographic barriers that negatively affected access to care. Two, the use of advanced practitioners, such as specially trained occupational therapists, physiotherapists, and nurse practitioners, as well as the use of community pediatric rheumatologists, improves access to care. And three, there was an inconsistent access to physiotherapists, social workers, and occupational therapists across Canada. I'm sure these findings are not restricted to pediatric rheumatology care in Canada. Depression is common in the general populations and in patients with rheumatic disease and results in a reduction of energy, motivation, and physical activity. Rathburn and co-authors in their paper titled Association Between Depressive Symptoms and Self-Reported Physical Activity in Persons with Knee Osteoarthritis longitudinally examined 2,602 patients with radiographic knee osteoarthritis from the Osteoarthritis Initiative. They found that depressive symptoms were not significantly associated with lower physical activity over time. The relationship between physical activity and depression did change over time in some patients, and that this relationship between the two was not linear from the time of the first to the fourth follow-up visits. The authors concluded that depressive symptoms may contribute to worse self-reported physical activity in people with knee osteoarthritis. However, it is not clear that this decreased physical activity related to depressive symptoms results in lower physical function over time. In Panorama 360 Degrees of Rheumatology, Highland and co-authors examined patients' perspective on a diagnostic experience in their article titled Patient Perspective and Clinical Insights in the Diagnostic Journey from Connective Tissue Disease to Pulmonary Arterial Hypertension. This month, we have two images in rheumatology. The first, titled Hydrocephalus-Related Dementia in Paget's Disease of the Skull, describes an 83-year-old woman with slowly progressive dementia that was characterized by a loss of short-term memory, decreased spontaneous activity, and speech, and apathy. Physical examination showed that her head was markedly enlarged, with significant bulging of the frontal bones. Radiographs showed an overall enlargement with diploptic widening, cotton wool appearance of the bones, and the so-called Tam O'Shanter sign. Bone scintigraphy showed increased uptake in the facial bones, skull base, and the calvarium. The second image is titled Mucosa-Associated Lymphoid Tissue Lymphoma as a Rare Mimicker of Relapsing Polychondritis. This article describes a 69-year-old woman who presented with persistent cough and hoarseness of 5 months duration. She subsequently developed bilateral lacrimal gland swelling, but there was no evidence of ear cartilage involvement. Laryngoscopy revealed prominent subglottic lesions, and a chest CT showed circumferential thickening of the wall, extending from the trachea to the bilateral bronchi. A diagnosis of relapsing polychondritis was made on the clinical presentation. However, subsequently, a lacrimal gland biopsy revealed a MALT lymphoma. I want to thank you for listening to this podcast and encourage you to read the complete articles, which may interest you in the May 2025 edition of the Journal of Rheumatology. These articles are available in either the print or online edition of the journal, the latter of which is available at www.jrheum.org. Please watch all the interviews of the authors of the highlighted article, not only from this month, but from previous months as well. They are available for viewing at our website and on our YouTube channel. If you have any comments or questions of any of the articles in the journal, please send them to manuscripts@jrheum.com. And please join me next month for the June 2025 edition of Editor's Summary. I want to thank you for listening.